Dr. David Sobel is the Medical Director of Patient Education and Health Promotion for the Permanente Medical Group and Kaiser Permanente, Northern California. He practices adult primary care medicine at the Kaiser Permanente medical offices in San Jose. Dr. Sobel completed his bachelor's degree in psychology at the University of Michigan. He received his medical training at the University of California, San Francisco, and then completed his internship at Presbyterian Hospital Pacific Medical Center. Dr. Sobel earned his master's degree in public health and completed a residency program in general preventive medicine at the University of California, Berkeley's School of Public Health. Dr. David Sobel is the co-author of 8 books, including Living a Healthy Life with Chronic Conditions, The Healing Brain, Healthy Pleasures, The Healthy Mind, Healthy Body Handbook, and What's the Catch? How to Avoid Getting Hooked and Manipulated. Dr. Sobel also appears on television to educate the public about health issues. His more than 200 appearances include The Today Show, CNN, and Hour magazine. He's the recipient of the National Health Track Foundation's Health Education Award, as well as the Kaiser Permanente James A. Vose Award for Quality, Exceptional Contribution Award of the Permanente Medical Group. Dr. Sobel is also an honorary fellow of the Society for Public Health Education.
For quite a few years, I've been thinking about the relationship between health behavior and health. And I've done this both as a physician as well as a patient. And so I thought I would actually start with my knee and my experience as a patient. So I had an encounter on a ski slope in which I blew out and tore some ligaments. So I went to see an orthopedic surgeon, and after an examination, she said to me, "Oh, my goodness, patient education, that's what you do? Well, there's the good, the bad, and the ugly." And what she then said to me was, "You are too old and you're not athletic enough to repair your knee." So I now had not only a bad knee, but I also had a bad self-image. So she referred me to a physical therapist who proceeded to give me 15 knee rehabilitation exercises to do. I call that an overdose of patient education. Well-intentioned. How many do you think I actually did? Any guesses? 2? 0. 0. So now, not only do I have a bum knee, a bad self-image, but I'm feeling guilty as hell and tormented by not adhering to the recommended treatment. Some years later, I visited a sports medicine specialist about my knee. My image of my knee at that point was I had no anterior cruciate ligament stabilizing my knee, and I had only a few remaining collagen fibers in my medial collateral ligament. Given that kind of mental image, how likely is it that you think I would do vigorous exercise? Probably not. The sports medicine specialist was able to examine my knee and actually demonstrate to me that I had much more stability in my knee than I had given myself credit for. And therefore, actually exercise would help improve that stability. Years later, I saw another orthopedic surgeon who examined my knee, put up my x-rays, and then stood back and said, "David, you have done such a good job of protecting your knee. I would have expected to see much more wear and tear on the cartilage. At this point, you've done a great job." So this is only my knee, and I'm only one patient, but this almost takes the spectrum of the good, the bad, and the ugly in terms of patients' education and its effect on people's mood as well as their health and their behaviors. Well, I've been thinking a lot about this behavior change and how do we engage people in successful behavior change. And what I'd like to do is I'd like to address 5 questions with you today. First of all, is behavior important in terms of health? We'll be able to do that one pretty quickly and easily. Second, is behavior change really difficult? We'll have some interesting thoughts about that. Is sustained behavior change through small steps the only and the best way to improve health outcomes? Finally, are people unmotivated? I don't know whether you've heard it. I hear it a lot from my physician colleagues. You know, I tell the patients what to do. I'm well-meaning, I'm well-intentioned. They just they're not motivated to do what I tell them to do. We'll address that. And then finally, how can we design behavioral programs that both set people up for success and also engage them in enjoying perhaps some healthy pleasures along the way? So that's our roadmap. Let's get started. Is behavior important? My guess is you wouldn't be seeing, watching, or sitting here today if you didn't think that that were true. But there's a lot of magical thinking about behavior. Is it really the magic bullet for the healthcare system? Well, there's no question that lifestyle and behavior determines a lot of the outcomes that we care about in healthcare. It'll determine health status very much, medical utilization and costs. It determines productivity at work, which our employer groups care about an awful lot. And finally, it's even one of the things that explains a lot of the differential and disparities that we see in health outcomes. In fact, when you look at it, quality excellent, cost outcomes, and so on are almost always touched, if not driven, by decisions and behaviors that our members and patients make. For example, our great quality scores depend upon people getting preventive services. That's a behavior. They take or decide not to take the prescribed medications. They use the healthcare services wisely or abusively. They improve their health behaviors from smoking to exercise to diet. In fact, the bottom line, when you look at our quality measures, almost all of them depend upon our patients, at the end of the day, changing their behavior. So the bottom line is, when we congratulate ourselves on our really outstanding Kaiser Permanente quality scores, some of that credit ought to actually be given to our members because the outcomes actually depend upon their behaviors. In fact, when Ernst Young, an accounting and consulting firm, did a whole analysis of the healthcare field, they came up with a rather startling conclusion. Changing behaviors represents the single biggest opportunity to improve health outcomes while bringing costs under control. So I think we're in the right place at the right time. Behavior is definitely important in terms of health and cost outcomes. But is it so easy to change behavior? Many of you have probably tried to change a behavior on your own and found maybe it's not so easy. So is it really difficult to change behavior? Now, I know this is going to look a little bit odd, but to address that question, I'm going to take you to a toilet. Not any toilet, a toilet in the Amsterdam Schiphol airport. Now, that toilet's very special because they were having a huge problem there. And the problem is, if I can be polite, guys just can't seem to aim. I don't know what it is about it. They're thinking about other things, but they create something called spillage. And this requires the cleaning crew to go in quite often and frequently, have to clean the toilets. They tried everything, putting up signs, everything. And then somebody came up with a very clever idea. Can anybody see what that is? Let me enlarge it for you. What they did is they embossed in the enamel of the urinal a small fly. And sure enough, spillage went down by like 80%. Now, why is that? It's because guys cannot resist trying to hit that fly. The general point I'm trying to make is behavior is difficult to change unless you really understand the drivers, the motivators, the cues, the environmental triggers. And sometimes, when you understand that, maybe not always, but sometimes the solution to change is really very elegant, very simple, and often not very expensive. So behavior change isn't rocket science, but it is a science. And our science draws from a huge body of scientific knowledge from health education theory, motivational interviewing, behavioral economics, health communication, social psychology. But that's not enough. We need to also reach into the marketing sciences, where a lot is known about shaping and changing health behavior, or gamification. I always pondered, how is it that anybody could have gotten my mother to go to Atlantic City to sit in front of a machine for 8 hours without moving, pulling a little lever? Somebody understood a lot about behavior design and behavior change, and we have to learn about that. And finally, in the entertainment industry, we're being shaped, manipulated, jerked around all the time because some people understand how to emotionally manipulate people, how to emotionally channel and direct people. Now, it turns out that I don't think you would come to me as a physician if I wasn't aware of the latest information and science that informs medical practice. Well, why is it that anybody would consult a health educator or someone in consulting who didn't actually rely on the evidence that supports their profession, namely the evidence of the behavioral sciences, broadly defined? Let me give you an example. Robert Cialdini has written a book called Influence. I think it's in its 5th edition now. Every time a new edition of this book comes out, I read it. And probably if there was one book I was going to read, it might be that, to understand at least social psychology and principles of change. He's developed principles of influence, and one of them is authority, and that's fairly straightforward. People are easily persuaded by individuals that they perceive to be a legitimate authority in something, i.e. a doctor. Social proof is interesting, and that is, most of the time, we look to other people around us, see the way they're behaving, and unless we want to create an exception, we usually say, hey, if everybody else is doing that, I probably ought to do it too. An example is you're walking down the street, one person's looking up at the sky, you're busy, you look at them, you walk right by. You walk down the street, 20 people are looking up at the sky. What are the chances that you're going to look up there? Because you're looking around, and if everybody's looking up there, hey, maybe there's something I should know about up there. And so you look up. And so social proof is an extremely powerful shaper and influences of behavior. And consistency as well. So people feel strong pressure to be consistent with who they think they are, their identity, and their previous behavior. And we can build on that. And let me give you one other principle. There's something called set completion, and that is we like to finish stuff. The closer we are to completing a collection, the more likely it is we're going to finish the task. So why is this important? Well, it begins to help shape our communication with our members, with our patients. Let me give you an example. We can make this a little bit more fun, a little bit more engaging, and improve the behavior change. So for example, here's a letter that might go out using these principles. Congratulations on getting your mammogram and your pap smear. What's that? Consistency. You see, people have already done something. They might do something else to stay consistent with that behavior. You have only 2 remaining gaps to complete your preventive care. Oh my goodness, that sounds like set completion to me. Mammogram is done, pap smear is done, congratulations. We got the colorectal cancer screening and the flu immunization. And then the majority of my patients are up to date. Please join them. So we've got an element of social proof. If other people are doing this, it probably makes sense I should do it too. And then we throw in a degree or two or a letter from your doctor, and you get the authority principle. It's not formulaic, but you begin to see that's a lot different than just sitting down and saying, I'm a nice person, I'm a kind of kind person, health education really helps people. Let me think, what should I write in this letter? I'm going to make it warm and personal. There's actually a science that can be tested, that can inform the way we craft our engagement with our members and patients. And finally, we're pretty boring. I mean, honestly. I mean, what are we up against? You see, here we have, why should I be tested for colorectal cancer screening? Now, do you think that's the only message our member is getting from their external environment? Probably not. They're probably seeing something like this. Now, I'm not suggesting that Kaiser Permanente should do an ad like that. I mean, we're not into red boots, maybe blue boots perhaps, but not red boots. But the point is, though we can't do that, could we do something that's a little more fun, a little more engaging before we blame people for being unmotivated and not willing to do what we're asking them to do? So let me give you an example of this. So we were asked to consult on outreach letters to remind people to get lab results and to get their lab tests done. And the idea was each letter from your physician would get successively more and more kind of prescriptive and embedding principles of social influence and so on. And here's my guess. I think this is testable, but my guess is if you already got 2 letters from your doctor asking you to get this test, getting a 3rd letter that had a few words changed in it and so on is probably not likely to push you over the edge. So we drafted, haven't tested yet, but it would be fun to test, a letter more like this. Hi, David, this is your heart checking in. It would be great to get an update on our cholesterol levels and blood sugar levels. To be honest, I'm really not sure how well we're doing. By the way, I also heard from your kidneys. Hey, and they're asking about the lab as well. Dr. X, Y, and Z has already ordered some routine tests, and they're waiting at any Kaiser Permanente laboratory. When do you think you might meet me there? Today, this week. That embeds intentionality. When you ask intention questions, people commit to the questions, their behavior is likely to go up. I know that the results could really help me keep my arteries open and keep you feeling well, ties back to benefits, and maybe even help Dr. XYZ make sure we're on the right path. Sincerely, your heart, and here are the fasting instructions and lab instructions. Now, I don't know if this is going to work, okay? It is based on some evidence and some science. I don't know. The point is, the 3rd letter from your doctor, the boring letter and so on, is unlikely to reach that patient population who hasn't responded before. And something like this is much more likely to get through, and at least it's testable. It could be a science. 3rd question. Okay, is sustained behavior change through small planned steps the pathway to health? Well, I want you all right now to think of a change you've made the last year or 2. Something, hopefully something related to your health. Some change. Now, when you've thought of a change, would you just raise your hand because you've got to get something specific in mind. Something you've changed. Raise your hand when you got something. No changes over here? Oh, intimidated social proof. Okay. Oh, no changes. Perfect to begin with. How can, you know? Okay, all right. Now I'm going to ask you a couple of questions about the change you made, okay? And you can raise your hand and answer yes to more than one of the questions, okay? So when you think about the change, did you plan and write out a specific small steps plan to get to your change? Raise your hand. Okay, congratulations, you 3. Did a major life event or an epiphany actually trigger a breakthrough change where suddenly you just changed something? Raise your hand. Okay? 3rd, did you make the change because your environment either made it required or just a whole lot simpler and easier to make that change? Raise your hand. Okay? And finally, did you make the change just because the behavior felt good and you decided that feels pretty good, I'll just keep doing it? Raise your hand. Well, I find this very curious. You see, we're in a group of health behavior change specialists, health educators, and so on. And our bread and butter for behavior change is usually getting people to do action plans and write out small steps. And you're not practicing what you preach. You're making all these changes through all these other mechanisms, and not necessarily through the one that we put most of our time and energy in. Well, that's curious. So let's think about it. There are different pathways to change. One is pleasurable change, happens to be one of my most favorite ones because it's easy, it's intrinsically motivating and self-reinforcing. There's breakthrough change. That's the one we know the least about, okay? I can tell you, I work with patients, and then suddenly they'll have a heart attack, and all these things we were working on, they don't write out a plan, they just change a bunch of things rapidly in a breakthrough style. Conversely, it doesn't have to be something bad. I walked in to see a patient, he was sitting there smiling. I said, "What's up?" He said, "Oh, I'm exercising, I changed my diet, life is great." I said, "What happened?" It wasn't like we hadn't tried to work on that. He said, "I fell in love." I'd like to bottle that. I'd like to put it in all of our pharmacies with 5 refills. A breakthrough change can come either through a disaster hitting bottom, but a breakthrough change can come when something really fabulous and special happens in your life. I had one when, after my son was born, I was driving home from the hospital, and I was listening to the news, and it suddenly occurred to me, the news will never sound the same way again. Because now as I listened to the news, I wasn't just listening to the news, how does this affect me? I was listening to the news, how does it affect the next generation and the generation after? A breakthrough change just triggered by an epiphany. There's environmental change, and that's hugely powerful. We respond either to a required change in the environment or our environment that just makes healthier choices easier choices. And finally, there's our bread and butter. Okay, I'm not leaving it off the list. Incremental plan change, my least favorite kind of change, but if the other things aren't working, it's a good go-to to have in your back pocket. It's sometimes called baby steps, small steps, simple steps, tiny steps, starter steps, success steps, or mastery experiences, and on and on. This is essentially a lot of what we do to try to encourage people to be healthier. So let me ask a challenging question. What if all those small steps do not lead to sustained change and ongoing health habits? Oh my God. Is that a disaster? I mean, have we wasted our professional training, our professional life? Should we hang up our spikes? Well, I'd like to look at that a little closer, and I'd like to tell you a story about Mullah Nasruddin, a tale of donkeys. Now, Mullah Nasruddin is a Middle Eastern joke figure. He's sometimes a wise man, he's sometimes a fool. In this story about Nasruddin, he was a very successful smuggler. That is, he got richer and richer. He would go across and back and across the border, smuggling, and the border guards each time would stop him. They would search him head to toe, including taking off his turban. They would unload all the saddlebags on the donkey. They could never catch him. He retired, and he was sitting in a small cafe, and one of the border guards recognized him and went up to him and said, "Oh, Nasruddin, look, we know you were a successful smuggler. Can you tell us, what were you smuggling?" And what did he say? Donkeys. Donkeys. So sometimes we are so busy looking for the active ingredient that we may miss the real important agent in change. We may take our donkey and so load it down with preventive care and smoking and exercise and addiction and medication adherence and so on, and those are important. But we may actually be missing the donkey as we go searching for all those other things. So what is the donkey in this case? How does health behavior or behavior change affect health in the first place? Well, there are the direct effects. And that is, I really would like my patients to exercise, to stop smoking, moderate their use of drugs or alcohol. I want them to sleep, get their preventive care. If I prescribe medications, I'd really like them to take it. All those things, if they do them, can have a direct effect on health. But the interesting thing that often gets overlooked is the indirect effect. of what happens when you successfully change something. What does that do to your mood, to your confidence level, and ultimately your health? Well, I first got on to this in 1986. I remember the article. Kate Lorig down at Stanford published a really interesting article about their arthritis self-management program. They got people together who had arthritis. They got better health outcomes. They had an educational program. They were all so excited. They did skill training, action planning. However, there was an interesting finding. We were able to demonstrate only weak associations between changes in behavior and changes in health status. That line caught my eye. That's kind of profound because we put all the emphasis on changing behavior, and yet a lot of people were getting better and they may not be changing their behavior, and other people were changing their behavior and not getting better, either in terms of symptomatology, medical care utilization, and so on. Well, how could this be? So focus groups were done and went to the people who were successful in the group, and they said to them, look, you got better, what happened? And they said, hey, I feel more confident, I feel more in control. And they went then to the people who didn't have improved health outcomes, and they said, what's up? And they said, it doesn't matter if I change my health behavior, I feel hopeless, helpless, and not in control. The key predictor, the strongest predictor of who had improved health outcomes was not the change in behavior. It was the change in their sense of confidence and sense of control. But since Kate Lorig was down at Stanford and Al Bandura, the psychologist, was at Stanford, it was called self-efficacy, or that a belief that one can change, the belief that one can do something, even if the belief is an illusion. So I've gotten to work with Kate Lorig and the team down there, and we developed a program, the Chronic Disease Self-Management Program. Here at Kaiser Permanente, we call it Healthier Living, Managing Ongoing Health Conditions. And again, it's based on a very similar principle. And we bring people together, and we may teach them small steps in action planning and behavior change, but here's the trick. We don't care what they change. We only care that they are successful at changing something that they care about, that builds their self-efficacy, that builds their sense of control, and that builds their confidence. So I'm not saying behavior doesn't matter. Please don't get that. In fact, small steps sometimes lead to wonderful sustained behavior change, and that does improve health, and that's what we rely on for exercise, smoking, healthy eating, preventive care, and so on. But I just want to point out that there's a donkey in this, and we may be missing the donkey, and that is small, successful steps. Confidence counts, can lead to success experiences that boost confidence, optimism, self-efficacy, and that itself has direct impact on health. And why this is so important is, think about it, as physicians, when we prescribe repeated failure experiences for patients, what are we doing to their sense of control and confidence? What are we doing to their health outcomes? When I get 15 knee rehabilitation exercises to do, and I do none, and I have a failure experience, I'm not only not doing the exercises, but at the same time I'm demoralized, and my health and ability to function is decreased as well. So what do we do about all this preventive care, exercise, diet, and so on? Do we chuck it out? No. But sometimes this sense of confidence and control can spill over and spread to other behaviors. Let me give you an example. There was a study done in New Zealand in which they only got people to focus on going to the gym and doing some exercise. They never mentioned any other health outcome except go to the gym and do exercise. And what they found is that the people whose confidence in self-regulation and control was increased Well, they found that they also decreased their smoking, their alcohol, their stress. They didn't lose their temper as much, and they didn't procrastinate as much. Furthermore, they were eating more healthy. They were keeping appointments. They managed their money. They could study better, and they could focus. None of those outcomes was mentioned in the intervention. But when you move upstream and what you focus on is increasing people's sense of confidence and control, sometimes it has a lot of unintended benefits. In this case, we always hear about unintended consequence. These are unintended benefits. Fourth question, are people unmotivated? Well, I hear this all the time. So, here's a picture of an unmotivated patient, right? And the consequences of that view is, first of all, we think our first job is to try to increase people's motivation, to pump them up, to get them to do something. That usually leads to prescribing some kind of failure experience for them. We get them really pumped up, motivated, they have a failure experience, and then on the part of us as health behavior change specialists or physicians or clinicians, we then feel frustrated and awfully cynical because the people aren't changing. Well, let me ask a couple of questions. Do we really know what motivates these people? I mean, before we label them as unmotivated, do we know what is actually motivating them? Two, how do we actually make it easier for them to do and accomplish some of the things that they want to do, that they are motivated to do? Not necessarily our top 10, but it's on their list. And finally, when they are successful at something, anything, do we focus on that? Do we celebrate the success of that? Or do we then focus on all the things they're not doing? And I can tell you, when patients come in, they're usually beat up. And by that I mean is they often, if they even come in, they come in and they already know all the things they didn't do. I hardly have to tell them that. They already know that. And so they're carrying with them already a litany of failure experiences. So let me ask you this. If you had limited attention, limited time, and limited resource, which part of the curve are you going to focus on? Are you going to focus on that part of the curve? In other words, the people who might be least motivated, most recalcitrant, most difficult to change? Or are you going to focus on the fat part of the curve? That is, that large part of our population that really does want to change, okay? They just don't know how, and we haven't made it easy for them. And if you remember your calculus, if you can shift that curve even a few percentage points, the area under the fat part of the curve gives you much more payoff and much more benefit than if you focus all your time and attention on the small end of the curve, the outliers, and so on. And truthfully, some of the outliers, you can't keep them out of the gym. You couldn't keep them away from eating healthy. Where we need to focus is on the large part of our population that aren't the, I do physician training sometimes in communications, and we'll do a role play in behavior change. And I can tell you, as soon as you get in the role play, that physician will pull out their most difficult, most recalcitrant, nastiest patient because they really want to stick it to me. And I say, can you have a little empathy for me? Don't do that. I mean, I'm not going to change them. There's no magic pill with that that's going to change them. But let's focus on finding something that they may be motivated about, that they want to change, and help them create a success experience in that. So target the ready and willing and help people, make it easier and help people do what they already want to do. So what do they want to do? And what are we focused on? Well, it turns out we're really focused on healthy lifestyles, okay? We're really focused on preventive screenings, exercise, and diet, and those are hugely important. But when you go and you talk to people about the immediate things going on in their lives that they care about, that they're vested in, it usually comes down in real life to the 3 S's, and that's stress, sex, and sleep. Now, they may not tell you that, okay? They often don't come in to the clinician and say, you know, it's really about sex. I don't have a healthy and satisfying sex life. Can you help me with that? They often don't come in saying that. But what we focus on is not necessarily what's most relevant to them. So a large survey was done, and they asked people, what are the things you're concerned about that you don't mention to your doctor? So this is kind of interesting. Here's exercise and diet issues. I wouldn't say those are the highest priority. In fact, what we've got here is job stress, caregiver stress, relationships, unhealthy sex life, and money concerns. Okay? That's what they're really concerned about: stress, sex, and sleep. So we need to begin to target relevant services that address people where they are and where their needs are. Success and failure. So it turns out that a lot of times when we try to motivate people to health, we talk about preventing long-term health conditions. Now, Michelle Seeger has done a wonderful job of describing this and wrote a wonderful paper called Rebranding Exercise. And it's like exercise has become medicalized now. You know, you'll exercise to prevent diabetes and prevent heart disease, or do body sculpting and weight loss and so on. And her studies suggest that the people who are motivated by that are the least likely to stay with the diet and exercise program. The people who are most motivated and likely to stay are the people who say, I'm exercising because I want to feel better. I want more energy. I want to be able to do things. In other words, they're more proximal, visceral goals. In a sense, it's the motivation that says a little more, what's in it for me right now, about how I feel. And that's more likely to engage people in the kind of sustained behavior change. So I've worked a lot in the area of healthy pleasures. Bob Ornstein and I wrote a book together called Healthy Pleasures, where we asked a simple question: is there any evidence that feeling good is good for you? And we found out that confidence does matter, happiness matters, and pleasures matters in terms of the senses and indulging in altruism. So I'm going to give you just a couple of real quick highlights of that, and then we'll talk about how to apply this in design work. Are happier people healthier? Well, people who answer the question during the last 4 weeks, how happy have they been, or how satisfied are they with their lives, those people turn out, when they're followed long-term, 2 years later, have 50% fewer health and long-term problems. There's the famous nun study. This was a study where they looked at the diaries of nuns when they were in their 20s, and they analyzed them 20, 30, and 40 years later. And what did they find out? Those nuns who wrote in their autobiographies of being happy and more joyful, they had 2.5 times lower risk of dying than their gloomier counterparts. And there's been a huge meta-analysis that was done looking at hundreds of different studies, and their conclusion is there's 7 types of evidence at least that indicate that subjective well-being, that being positive emotion, optimism, and so on, causes better health and longevity. The evidence is clear and compelling. So it turns out that we can begin to apply this, that happiness is related to health. And what about happiness? What determines that? Well, they did a study where they had people carry around an iPhone, and they would randomly beep them during the day, and they would ask them 3 questions. What are you doing right now? How are you feeling right now? And what are you thinking right now? And it turned out about 50% of the time, when people are beeped, they're thinking about something other than what they're doing. Their mind is someplace else. People are happier when their mind is not wandering, no matter what they're doing, pleasant or unpleasant. In other words, if I am sitting on the beach in Hawaii, sipping a chichi, meanwhile my mind is 3,000 miles away thinking about KP Health Connect and charts, the chances are I would be happier if I was at home carrying out the garbage mindfully. That is, really being present with my garbage. It is where your mind is focused is more highly predictive of whether you're happy or not, whether it's pleasant or unpleasant. What we are thinking is a better predictor than what we're actually doing. So what about savoring our senses? There's huge evidence now on the benefits of touch. And Tiffany Fields at the Massage Research Institute at University of Miami has done randomized trials in a whole variety of populations, showing, no, it's not the cure for disease, but it helps people feel better, cope better, and you get better outcomes. What about enjoying our senses of looking at nature? We evolved to look at nature, and it's such a simple, pleasant thing to do. It's not a hard behavior. It's not an unpleasant behavior. When patients who were admitted for surgery looked out and saw nature in a wooded tree scene, were compared to the patients who were admitted to the same hospital on the other side of the ward, and they looked out and saw a brown brick wall, it turns out those who look at nature have less distress, require less pain medication, and even get out of the hospital as much as a day sooner. There's something called nature deficit disorder there. Have you ever heard of that? No child left inside, okay? It's like this is the first generation in which the exposure to nature among our children, our biological heritage, our exposure to nature is actually being compromised and reduced. I like chocolate, okay? And it turns out there's an enormous evidence now that chocolate, especially dark chocolate, actually has some health benefits. Now, that's not a difficult pill to swallow, is it? 27% lower relative risk of death, and chocolate eaters tend to live a year longer. They have lower blood pressure, 47% lower mortality rate in men. Women who have just one small bar of chocolate per week, if they're over 70, much less likely to have cardiovascular disease or hospitalization. In men, reduced risk of stroke by some 20%. And what about sex? Well, I could give the whole talk on sex, and I'm sure you wish I would have started there. But I came across this study that the Brits did that showed the risk of death in men who had sex twice or more a week was half that of men who had sex less than once a month. And that was after controlling for pre-existing conditions and heart disease, social class, age, smoking, and so on. When I sent this slide to our audiovisual department, I had a beautiful graphic there, and they said, where do you think you're going with that? I said, well, I'm going to talk to some mature adults. I think most of them have seen that. And they said, no, not with Kaiser Permanente's name on it. We're not letting you out with that. So I begged them, and all they would let me have is this. Funny thing about this study is I was real excited when I got it because I emailed it to my wife. I could not wait to get home. So she greets me at the door, and I said, Judy, did you check your email? Oh, yeah. I said, did you see the article? Did you read it? You know, twice or more a week, we're already behind here, and so on. I said, do you realize you could save my life? And she looks at me and she says, you're going to die. Siestas. I love the study done of showed 30 to 50% less risk of death in men who would take a siesta, and then they extended the study to 24,000 people. Occasional nappers, 12% reduction. Frequent nappers, 37% reduction. Now, since my specialty is preventive medicine, I find this study really reassuring, because as I look out, even in this audience right now, I see that I'm practicing preventive medicine. That some of you are taking advantage of this time for napping, but at least you're reducing your heart disease risk. What about laughter? A small study done that showed that the prescription was watching a funny video for 30 minutes. And they had fewer irregular rhythms, lower blood pressure, less medication. Surprisingly, they had 1/5 the rate of recurrent heart attack in the follow-up period. Again, we haven't focused on some of the natural, enjoyable things in terms of behaviors that people might be motivated to do that actually have promising health outcomes. What about owning a pet? Someone did a study that showed that pet owners, following a heart attack, were 1/5 the rate of recurrent heart attack compared to those who were petless. And it didn't matter if it was a dog that you walked and got the exercise, fish. I had a python. I don't get much exercise with the python unless Freddie gets out of the cage, in which case I'm frantically running around the house trying to get him back in the cage before my wife comes home. But you get lots of hugs. And then finally, what about altruism? It's not all about indulging in things that we enjoy. It's also about caring for other people. And you all know the importance of social support. One of the surprising findings to come out of all that literature is in terms of health, it's actually better to give social support to someone else than to actually receive it in terms of mortality. And so that again starts to suggest the pleasure and enjoyment that people have of giving and caring for other people actually improves their own health. And finally, just a quick example. A lot of bad things happen to everybody in their life. How do we create some good, positive experiences that happen? So, does anybody have $1? Just $1. Okay. All right. Oh, thank you. So you're walking through a shopping mall, and you see a $1 bill down on the ground. You look around, nobody's dropped it. You go, oh my God, did he drop it? No, You go, it's my lucky day, and you take the $1 bill and you put it in your pocket. Now, would you think that finding a single $1 bill would make nuclear war less likely? Do you think that finding a single $1 bill would make you happier with your spouse or your significant other? Do you think that finding a single $1 bill would make you confident about your refrigerator and likely to buy the same brand? They've done the study. It turns out we don't actually face the world and reality directly. We face it through a set of cognitive filters and also emotional filters. When something good and unexpected happens to us, it changes our mood, our emotional filters change, and suddenly nuclear war is less likely. Our spouse is terrific. That refrigerator is rock solid. The problem is it doesn't last long, which is why it is so important to fill your day with those very small things that boost your mood and change your entire view of the world as well as your view of yourself. Now, Andrew, thank you. Does this count as giving to somebody else? I don't know. So the last question is, then, how do we apply this? How do we design for success? Well, let me just start with a quick formula for you. I have a graduate degree in prescribing failure experiences. I have extensive training. I've done it to myself. I've done it to my spouse, my son, and I do it to my patients. Here's the formula. Choose a behavior that's prescribed. You tell somebody else something to do. Make it really general. You have to be more active. You have to exercise more. You have to be fit and healthy. Make it pretty difficult. Make it long-term. I am not talking about just for a few weeks here. This is a lifelong commitment that you're making. And finally, if you can, make it unpleasant. I almost guarantee you'll have a failure experience. Great. Well, I actually call this behavioral malpractice. And being a physician, you're supposed to at least do no harm. And I would submit that this is behavioral malpractice. And yet we do it all the time. So how do we reverse that? What does prescribing success look like? First of all, it's very personal. Okay? Person is doing and selecting something that they care about, that they want to do. Then it's got to get really specific. B.J. Fogg, the psychologist, calls this crispy. Behavior has to be really small, specific, so that you'll know whether you're doing it or not doing it. It needs to be easy. In the work we did at Stanford, we developed something called the confidence test. When somebody sets a small goal, you ask them, how confident are you that you're going to be able to accomplish that? And if it's less than 70 to 80%, chances are they'll fail. You get them to rescale or shrink the change a bit, rescale so that they can be 70 to 80%, they're going to be able to do it. I like rapid change things because you get some immediate feedback, and to the degree that you can make whatever the behavior is pleasurable, It's a chance to be more intrinsically rewarding. And then finally, you got to celebrate success. Now, something new I've been thinking about a lot, and I just want to share with you, and I call this a partly baked idea, so maybe I can get your help in baking it a little bit further. There's something called priming, and that's when a suggestion comes into us unconsciously and it changes our behavior. So, for example, if I started talking to you or you read an article about geriatrics, the classic example is if you were then asked to stand up from a chair after thinking and hearing about geriatrics, you're likely to get up from the chair a little slower. That's unconscious priming. The thing I've gotten interested in is conscious priming. That is when we plant a seed or a thought that makes us more sensitive or primed or more aware of things like opportunities or things that are happening around us all the time that we're on automatic pilot and we don't see, that we see interactions where we ignored them before. We see triggers where we might have ignored them. So one of my favorite examples of this is the work that's been done around gratitude. Emmons up at the University of California at Davis has done a lot of research that's showing if people will do a very simple exercise and sit down at the end of a day and ask themselves, what 3 things happened today that I'm grateful for, and write them down. A whole variety of studies now, not only on mood, but on physiology and health outcomes and doctor visits and so on, go down just by focusing on the things that we're grateful for. Now, I tried this exercise, and that's what got me interested in this notion of priming. Because I knew when I was sitting there writing about things I was grateful for, I was going to feel good. Here's what I had not anticipated. What happens the rest of the time? Well, we're about halfway through this day. I'm going to face a blank sheet of paper tonight. I'm already starting to get a little nervous and anxious. Have I identified 3 things that I'm grateful for today? So, boop, up go my antenna. I begin scanning my environment, looking for and seeking out and noticing and celebrating the things I'm really grateful for. And so, therefore, it's not just what happens during the 3 minutes it takes you to do the exercise. It's the way it primes you so you can ask at the end of the day, what am I grateful for? Or try this one. What happened in the last 24 hours I was really curious about? Got my curiosity going. What surprised me most in the last 24 hours? What did I learn new in the last 24 hours? And you can begin to see as you program yourself, in a sense, you're going to start noticing the next day the things you're looking and seeking out that you're going to find that you learned new. So, for example, I love this example. I read an article that there was a shortage of toilet paper in Venezuela. Seems like a small thing. Yeah, you try it. Suddenly, I realized another thing you can ask yourself, what are all the things I take for granted? Okay, like toilet paper. It begins to sensitize you and get you appreciating your assets, your resources, instead of your limitations and disabilities, and builds confidence. I'm not sure what to call this. Maybe you'll noodle it around and give me some ideas. Is it a priming? Is it a ripple behavior, a cascading behavior, a domino behavior, a keystone behavior? Whatever it is, I think we're on to something if we can find the few things that have real cascading effects that change not just in that moment, but change people's cognitive filters and emotional awareness. So I'm going to end by telling you 3 quick tales. I'm going to talk about trout, tide, and tires. Trout. This is a patient. Actually, it's not a patient. I'm respecting HIPAA. This is actually, he looked a lot like Paul Giamatti, my patient. He was middle-aged, he was overweight, hypertensive, hypercholesterolemic, sedentary, and had diabetes. For about 5-7 years, I had worked with him, and I had tried about everything. Motivational interviewing, couples counseling, sent him to the diabetes education program. I even tried guilt induction. I pulled out my quality scores. I showed him how his hemoglobin A1C was pulling down my quality scores. I said, look, if you won't do it for you, will you help me out here and at least, help me? Nothing was working. And one day I asked him, what do you really enjoy? You see, I could tell you all the facts of his life. I could tell you his job, his occupation, how many children he had, and so on. But I suddenly realized I had no idea what he enjoyed. His whole face changed and he went trout fishing. I love to go trout fishing. I love standing out in the stream. I don't care if I catch anything. I just love being out there. 30 seconds went by. And this patient probably has taught me more in my clinical practice than any other patient I've had. First of all, I understood that I didn't understand the whole person. That all these people who I had been seeing, I couldn't tell you what really animated and motivated them, what they really enjoyed. Second, I had just done half the screening for depression. Because had he sat there and said, nothing, I don't enjoy anything, I can't think of one thing I enjoy, then you have to think depression and finish the screening for depression. I now understood that hemoglobin A1C and control of diabetes meant nothing to him. Trout fishing meant everything. So what's my job? Somehow to connect, keeping him out in the trout stream, fishing, doing what he loves as long as possible, aligning with that intrinsic motivation, and showing him how controlling the diabetes, he could keep his vision, he could keep his legs, he wouldn't have a stroke or less likely to have a stroke or a heart attack, so he could do what he loved. And finally, it was a bright spot and a health promotion program for me as a clinician. You see, most of my day in primary care medicine is back pain, dizziness, shortness of breath, acting out teenagers, joint pain, non-adherence to medication, obesity, diarrhea, vomit. I could go on and on. It's not a real pretty picture. And for a moment, I get to go trout fishing. For a moment, I get to repair broken children's dolls and donate them for charity. For a moment, I get to restore a 1967 cherry red Camaro to pristine condition. You see, it helps us understand what helps our patients really thrive. You know, because truthfully, I did not go into medicine to manage hemoglobin A1C. If my epitaph says, oh, he got good quality scores, I'm sorry, I don't count that as a great success. I don't care about the hemoglobin A1C. I care about helping people do what they really want to do to thrive, okay? And so therefore it helps connect me viscerally with what's most motivating in my practice and in my life. Medicine's not like that. There's no improvement, Henry. You're sure you've given up everything you enjoy. Well, I think we need to screen for pleasure. We need a new and vital signs. So I've been encouraging many of my colleagues just to ask a few patients, what do you really enjoy? Putting a little juice behind it. We do exercises in some of our classes and programs where we have people list those activities. There's even a 320-item pleasant event schedule that you can fill out, and it says, how much do you enjoy it and how often do you do it? I love some of these. Yeah, I love this. Going naked, going to a sporting event, doing military exercises. Trust me, they got just about every pleasure on this that you can think of. And in terms of unconscious or conscious priming, when you read the list, you start to say, hey, I might enjoy that. Maybe I'll try it. And then finally, we're encouraging physicians or just people around the office to just fill out a little poster outside their cubicle or office which says how I thrive, and share with the people around them what you really, really enjoy, as I've done. The second story, so the first about trout, the second, well, it's about a patient who couldn't remember to take her medications. And my usual response is, please take your medications, it's going to help you. That doesn't work. Then I flood them with a tsunami of suggestions like, put a reminder on the refrigerator, do you brush your teeth, put a note by your toothbrush, and you know how patients say no to a doctor? Yes, doctor, whatever you say. That's how they say no. And they don't do it. Or I paused for a moment and I said, sounds like you want to take your medications. Do you have any ideas what might work for you? She paused for a moment and she said, I've got it, the Tide box. I said, what? She said, whoops. She said, I'll put the reminder on the Tide box. I do laundry every day. I go out there. I see the Tide box. It's got a note on it. It'll remind me to take my medicines. So here's the question. How long do you think it would take me to come up with the Tide solution? Okay, I don't do laundry. I would never think of that. That's a brilliant solution. Patient-generated solutions are far, far more likely to be ones that are workable and that they adopt and can do in their lives. Third, celebrate successes. So I took my car in to a car shop to get the oil changed and so on. Nothing was wrong with it. The guy walks around my car and he looks at the tires and rims and he comes back and he said, David, I've got good news. He said, it's amazing. You have taken such good care of your tires and rims. I would have expected to see much more wear and tear at this mileage, and I seldom see this. Congratulations. Well, how do you think that made me feel? I felt great. You know, I even had a new identity leaving the car dealership. I was now a protector of tires and rims. I'm driving down the road. I go into a turn. Easy, easy. Easy on the rubber. I don't want to hit the rims and so on. It's so simple. So simple. When the orthopedist put up my x-ray and said, David, you've done such a good job of protecting your knees and your knee cartilage, I would have expected to see much more wear and tear. 20 years later, I remember that phrase. 20 years later. How often? We're like heat-seeking missiles for failure experiences. Patients come in, we identify all the things they're not doing right instead of finding some of the things they're doing, and yes. So when you ask a patient, are you having any difficulty remembering to take your medications? And the patient says, no, I remember them all the time. I take 100%. I go, that is fabulous. That's really helping to control your blood pressure, etc. And I wish I could get you to teach my other patients how to do that and be successful like you are. Small things of celebrating. So, Tide, and tires. First of all, discover their passions. Before we call people unmotivated, let's find out what they really are motivated about, what they enjoy, and can we align with that motivation to help them change. Second, instead of prescribing all kinds of solutions, first invite their solutions. If they can come up with nothing, think depression. If it's not depression, then ask, well, would you be interested in hearing some of the things that have worked for some of my other patients or clients or whatever, and share some of those and see if any of those might pique their interest. And finally, find something that they've done right and help them celebrate. I use celebrate rather than praise, acknowledge. Acknowledge is not visceral enough. Praise is kind of condescending. Celebrate is something we do mutually because it's got to be genuine. If I mechanically say to every patient, congratulations on this, it's not going to have that emotional content, the emotional feel. So find something unique, something special that they've done, and celebrate that. So, 5 questions. Is behavior important? Yes, we decided. Is a behavior difficult to change? Well, yes, unless you apply behavioral science, or at least exercise the best judgment we have around the evidence that is available. Is sustained behavior change the only path to health? Success and confidence itself, even if the behavior isn't sustained, can lead to health outcomes. And people, are they unmotivated? Well, sometimes yes, but often they're not. In fact, pleasure matters, confidence matters, success matters, and most of the time we don't know what they're motivated about because we don't ask. And how do you design with pleasure? First of all, when you're designing, emphasize the more proximal, immediate enjoyment, successes that people can celebrate. Second, don't be senseless. Let's not be afraid to include the senses and sensory enjoyment and pleasure in what we design. Celebrate even tiny, small successes. Include unexpected delights and surprises. One of my mentors, Laura Kiernan, who was director of health education, her aunt used to give her tickets to a concert, never on her birthday, never on a holiday, always just completely out of the blue and unexpected. And finally, if you can work with me, we can identify some of those priming or cascading behaviors which have all kinds of payoffs that are real simple, but really can affect outcomes. And whatever you do, find your thing. Thank you very much.